Good afternoon, everybody. Thank you for your patience. It's really great to see you all today. Thank you for being here. Welcome to today's public policy lecture. My name is Andrew Reeves. I am a professor of political science, as well as the director of the Wiedenbaum Center. The Wiedenbaum Center is a research institute that supports social scientific research here at Washington University. Our mission is to foster thoughtful, research-based discussions that bring depth and nuance to some of the really complicated public policy issues of our time. In addition, the Wiedenbaum Center supports faculty research with hundreds of thousands of dollars every year, as well as administrative support for grant work here at Washington University. We also sponsor public affairs programs like the one today. And our goal is to serve as a bridge between scholars, policymakers, and the public. Our center is committed to creating a space where difficult questions can be explored from multiple perspectives, where evidence-based dialogue can flourish, and where the insights of experts are made accessible to all. This mission is part of our legacy, and it's one that we are strongly committed to. Today, we are so honored to hear from Health and Human Services Director Melanie Fontes Rainer. Director Rainer will give her remarks, and then we will open it up to some Q&A. Let me go ahead and kick things off with an introduction. Melanie Fontes Rainer serves as the Director of the Office for Civil Rights at the U.S. Department of Health and Human Services, where she leads the department's enforcement of federal civil rights and privacy laws, and she directs related policy and strategic initiatives. Previously, Melanie served as counselor to the HHS Secretary Javier Becerra, providing strategy guidance to the Secretary on issues pertaining to civil rights, patient privacy, reproductive rights, the Affordable Care Act, competition in healthcare, equity, and the private insurance market. In this role, she led the implementation of the bipartisan No Surprises Act, helping to increase transparency in medical billing and saving consumers money. Before joining the Biden-Harris administration, Melanie served as the Special Assistant to the Attorney General and Chief Healthcare Advisor at the California Department of Justice. She also previously served in the U.S. Senate as a senior aide in women's policy and women's policy director to Chair Patty Murray on the health, education, labor, and pensions, and the budget committees. Melanie has a JD from the University of Arizona, MSME from the City University of New York, Brooklyn College, and a BSBA from the University of Arizona. Will you please join me in welcoming Director Rainer?
I'm still doing my slides from this right here, yeah?
Yep.
Okay.
You can just hit the arrow to advance.
That.
Yep, perfect.
So hi everyone, I'm Melanie Fontes Rainer. I am, for the next 67 days, some of you got it, the Director of the Office for Civil Rights at the U.S. Department of Health and Human Services. I'm a political appointee. I'm appointed to my position by President Biden and Secretary Becerra. So I will turn in a letter of resignation on January 20th. But my office will continue doing its work with civil servants, and then the new administration will appoint a new person to run the office. Our office is a federal civil rights office. We are, every single federal agency has a federal civil rights office. When I talk to folks around the country, oftentimes people do not know that there is federal civil rights offices outside of the Department of Justice. So we are the second biggest civil rights agency to the Department of Education, and then of course Justice, and then a lot of the other agencies are much, much smaller in their staff sizes and resources. Obviously their agencies are smaller as well. HHS has 80,000 employees nationwide. So we work on civil rights across programs and services at HHS, which we'll talk a little bit about. We have the only civil rights office in the entire country that also is charged with enforcing privacy and security under HIPAA. So it gives us a super unique vantage point as we think about all the things that are happening across the country in state laws, federally. We think about the nexus of how you interact with the healthcare system, your civil rights, and how your medical information may or may not be being used. So that's just a little bit on our office. We have offices in 11 cities across the country. We don't have an office here in St. Louis. We do have an office in Kansas City and an office in Chicago, as well as we have staff really scattered all around the country. And then I will just add, I'll talk about 3 priority regulations we worked on in this administration. We can talk a little bit more about like what might become of them, what's happening to them in the courts, what a future administration may or may not do. But I think important just to talk about these are some of the priority areas of this administration, which of course comes to the terrain of like the executive branch, right? The president gets to have the president's priorities. So federal civil rights laws, we think about protected classes. So things like race, national origin, sex, which as of a few years ago is inclusive of sexual orientation and gender identity, as well as pregnancy and pregnancy-related conditions. We're being sued on that right now, so more to come. Age, disability, and color. These are our protected classes. These protected classes exist across federal agencies and most laws. With respect to those protected classes, when we think about the protected classes, we think about how do these laws protect federal rights, access to health and human services, and how the government itself provides those services in certain instances, right? Like, for example, I don't provide services because I run a law enforcement policy agency, but the National Institutes of Health, in addition to giving out grants to academic medical centers and researchers, they also have a cancer institute. They have hospitals they run where they perform services, similarly with Indian Health Services as well as the CDC, which they're in a very different position than some of the other agencies. So the federal civil rights laws we'll talk about, or this is just a snapshot of them. I will say my office enforces 55 statutes across the federal government. That's a lot, and that's not inclusive of HIPAA. So a lot of those laws were actually added during the previous Trump administration. A lot of religious conscience statutes were added to HHS's Office for Civil Rights Enforcement practice. When I took over my job and was looking at the conscience regulations and rules, we were broached with the question, do we keep these delegated authorities? They exist in law. The secretary issues a delegation of authority to my office to enforce them. So obviously, if you can issue a delegation, you can also rescind a delegation. I made the decision alongside my colleagues to keep these statutes because, again, we were trying to make sure it was a focus of the previous administration. We wanted to make sure that work continued. And we're trying to, on some of these areas, stop what I'll call light switching with civil rights. So I think we can all have difference of opinions on various things. And I will say this in any room I'm in, federal civil rights should not flip on and off depending upon who the president is. So again, I'm a Democrat, you know this because I was appointed by President Joe Biden, understandably had different priorities than my predecessor. That doesn't mean that while he was here, he didn't do things like language access or disability policy. And while I have been here, have done a number of conscience work, conscience rules that were their priority. So again, those things should continue. More to come on that as we see these things unfold. But I think important to note that some of the strategic things we did in thinking were, how can we start to insulate some of this work from the politicizing of civil rights? Some of it I think is just inherent in the populations or the dynamics, and they're just probably never going to go away. But I do think there are ways in which we as a government can start to think about how do we make this more of the book of business and the practice that no matter who is here, they're prioritizing this stuff versus I'm only here for this amount of time. I'm only going to do X and Y, and the rest of civil rights can just take a back seat. So across the federal civil rights laws, we have Title VI of the Civil Rights Restoration Act, which has been a long, long time in the law. It's actually what created my office in the first instance. When HHS first had a civil rights office, it didn't actually have staff. So there was one person who worked in this, that's right, right? So we had an office, there was one person who worked in the office, and at the time, hospitals were segregated. So HHS took it on to work on desegregating hospitals across the US, but they didn't have any staff, they didn't have any lawyers, they didn't have investigators. They took volunteers working with the various legal institutions like the American Bar Association. They took volunteer pro bono lawyers to come and to do investigatory work across hospital systems to desegregate the hospitals. And I flag that in that that was both the infancy of the office. I think we all can't remember a day when hospitals were segregated in our lifetime. I mean, maybe some of us, I don't know how old people are. Don't pretend to know how people older are. Sorry if I offended you. But I think it's been a long time since we've actually seen that. I understand, practically speaking, you could make the case that hospitals are in some ways still segregated by socioeconomic class, which may also have racial implications. But this was something that happened in the 60s and something where there wasn't actually paid civil servants to do the work. And so since that time, of course, we've done a lot of work in this space. Section 1557 of the Affordable Care Act. How many of you knew the ACA, Obamacare, had a civil rights provision in it? 3 people. So it does, in addition to all the other things it does, it has a provision, and we'll talk more about it. It's pretty broad, non-discrimination in health programs and activities, and it reincorporates all of the protected classes we talked about in underlying statutes that are tied to them. And then Section 504 of the Rehabilitation Act, does anyone know what that does? Discrimination on the basis of disability. It actually predated the Americans with Disabilities Act. It was the first law passed. At the time when it was passed, it was quite controversial because a lot of hospitals did not want to pay to make accommodations for people with disabilities, and they were very opposed to it. And so even after it passed as a law, the administration at the time sat on it, and they didn't do rules, and there were systematic protests across the country to get the administration to implement rules. So in San Francisco, New York, and Washington, D.C., our current office, people with disabilities, alongside other civil rights organizations like the Black Panthers and others, effectively occupied those buildings and protested until the secretary then signed those regulations into effect. And again, I flag that because that was when those regulations were first promulgated back, I think almost 50 years ago now. We just updated that reg for the first time in 50 years. And I'm sure you can imagine over the course of 50 years, how we talk about people with disabilities, how we think about them, the biases, the stigmas that maybe were written into these rulemakings has changed a lot, including the policies in terms of things like Medicaid and home and community-based services versus institutionalization, which is now something is like a health policy focus area in the community. And then Title IX. Title IX is tied into 1557, so that's how we get it in healthcare. But we also at HHS have some programs that are not exclusively healthcare. So for example, Head Start, right, which folks have heard of Head Start, that is an HHS funded program. It is not a program that has healthcare, it is educational services, but it is provided by HHS. So it's not covered by 1557, but it is covered by Title IX. And so HHS also has a non-health, non-education Title IX rule for certain programs and services. We talked a little bit about the conscience statutes and the Religious Freedom Restoration Act. And then we develop policies, which we'll talk a little bit about, which I think is really an important thing within the government. And we enforce these laws nationally. So across the country in all 11 offices, we have 91 investigators. So 91 investigators to do cybersecurity under HIPAA, privacy under HIPAA, and civil rights. So does anyone think that's enough investigators? Yeah, it's not. But we're very strategic, and we work really hard to educate Congress and others about the needs of the office. And I think as cybersecurity is a growing area of bipartisan issue, potentially there's opportunity to think about that with OCR's role in that, where we're the law enforcement agency at the Department for Cybersecurity. Okay, so Section 1557 of the Affordable Care Act, underlying statute is very broad. It's a couple lines, it doesn't say much, so the regs do a lot of work. When these regs were first promulgated back in 2016 under President Obama, there were discussions about whether they should do any reg at all, right? Some folks thought, just let this be a self-executing statute. Others thought, no, you have to be very specific about the rules, And you want to be very clear about what this covers to covered entities, whether it's a health plan or a provider, to be very clear about how you're going to enforce it. I think when I first started my journey into the executive branch, I agreed more regs was best. Now that I've had this job for I'm on my almost third year, and the environment is so litigious, I'm being sued 5 times over this rule, the next rule 1 time, and the next rule after that 3 times. So I would say now, probably I would think more in the camp of less is more here, do it through your enforcement work as opposed to prescriptively writing rules. That being said, who knows, my prescriptive could change again, but I think as like a lawyer going through this process, I certainly feel very strongly about that now. So this rule we talked about protects all the protected classes. It covers things like Medicaid, Medicare, for the first time, private insurance market, which we know is inclusive of the Affordable Care Act itself, and it covers things where there is the principal engagement of healthcare as a business. So it can get to self-insured employer coverage. It can get to certain limited accepted benefits, things like dental plans that you might find outside of a normal health insurance market. And it's inclusive of all of our civil rights. So language access, I think for a lot of, do people know what I mean when I say language access? What do I mean? Yes, so providing services in a culturally accessible, accommodating manner for a community or person. What we know is it is 2024, and this continues to be an issue. And I think a lot of people think it's not necessarily a big issue, but we just had a case about 2 years ago now. So Maricopa County, do folks know where that is? Yes, my home state of Arizona. It is the biggest county in Arizona. You all know about it now because Arizona is sort of a swing-ish state, arguably. And Maricopa County is also one of the largest Spanish-speaking communities in the entire country. Their superior courts, so a government entity, were not translating court documents or providing translators in the child welfare context or to people that needed the services. So parents were getting their rights terminated in a language they did not understand, and the courts were not doing anything to help those parents understand where their kids were, how those decisions were being made, judicial services, et cetera, in that language. So to me, that makes my jaw drop a little bit because it's in a giant city, a giant county, and in a community where Spanish is like very highly spoken and a lot of people need the services. So we entered into a settlement with Maricopa County under Title VI, and now we're monitoring them. They're providing translation of services. They're providing the interpretation of services. But I use it as an example because there are a lot of different languages spoken in many of our communities, right? I just did a language access roundtable in St. Louis yesterday, and we had folks from various Afghanistan community, various Chinese communities where they were talking about the need for language accesses here in this community. And so thinking in a community where the Spanish is like, that is like the floor, thinking about like things like Chinese dialect or indigenous languages, those are certainly not being translated. So this rule makes clear that language access services be provided free with privacy parameters taken into consideration so that your healthcare business is not announced to, say, a lobby or another patient. We reinstated those protections. Things like LGBTQI protections, we're being sued all around the country on this. All this to say is we did include a provision in this that said you cannot categorically deny someone healthcare. So if, for example, an individual was LGBTQI and they needed a particular service, the fact that they were LGBTQI shouldn't preclude them from getting everyday healthcare. Meaning if I were to get a mammogram somewhere, my gender identity or sexual orientation should not preclude me from getting a mammogram. It's different with specialty care because, of course, specialty care is provided differently around the country and different providers. But you can't just deny someone services because you don't want to treat a general population of this. And that would go across for race, sex, and any other protected class. As well as sex-based discrimination that includes sexual orientation, gender identity, pregnancy, and pregnancy-related conditions. Now, we're being sued in Florida, Tennessee, Missouri is in another lawsuit, Montana, and Mississippi. And in those 5 suits, we've been enjoined several times nationally from any gender identity provisions. So gender identity, the argument being gender identity is not inclusive of sex-based discrimination. And in a court in Texas, they nationwide precluded us from doing any sex-based discrimination. So not just sexual orientation, gender identity, just gender, pregnancy-related conditions. So right now, we're getting a lot of incoming from members of Congress asking us to look into these cases of women dying and things like that related to pregnancy care. And I have to tell them, I can't do anything. I'm legally precluded from doing anything right now, right? And so just understanding the dynamics of when these lawsuits happen, when they have national-wide implications, affects these rules pretty strongly. And I will say, on the LGBTQI front, when I started this job, we were being sued under the Trump administration rules. Then when we got there, they started suing the Biden administration for not moving quickly enough on new rules. And now we're being sued on our rules. So simultaneously, we're being sued on, I don't know the total number, but we're being sued multiple times over across the country, on both sides of the aisle for various iterations of interpretations of this law. Which is to say it is what it is, and those things will work themselves out, but just goes to show you how litigious I think rulemaking is, in particular in a civil rights office at this moment in time. And then disability, as well as the first artificial intelligence non-discrimination standard. So our rule requires identification when one of the protected classes is an input variable into artificial intelligence. So identification of possible risk. So whether it's the National Academy of Sciences or the AMA or some pressure testing that the developer themselves have provided, that puts you on notice about possible risk. There's a lot of conversation right now about assurance labs and collectively using like academic medical centers to do some of that testing because obviously there's a lot of variation across our healthcare system. There's small providers, there's very rural providers that might not have that sophistication or resources to do that testing. So trying to work through public-private partnerships to do some of that testing. And then once you do identify that those protected classes are part of that, making sure that you're mitigating any possible risk. So if you determine that it might be discriminatory against people with disability, pausing to figure out what you're doing wrong. Things like auditing use, training of people that use artificial intelligence, registries so you know what's happening in your hospital, things like that. And then Section 504 of the Rehabilitation Act is, we talked about disability discrimination. So these regs, when the Biden administration started, disability advocates across the country were writing into which I'm sure people are doing right now, we're writing into President Biden and the incoming administration and saying, please, you have to update these rules. They're old, they use inflammatory language to discuss people with disabilities. They're not up to date on court cases, they're not up to date on practices, and frankly, your own enforcement experience shows that. Meaning we continue to enforce the law. We've seen a lot of these things happen in real time through law enforcement, which is part of the basis for rulemaking. So ensuring medical decisions aren't based on stereotypes or bias. So an example of that was during COVID-19. There were a lot of policies in place that said who got shots, who got ventilators, and sometimes those decisions weighed a life with a disability as less than a life without a disability. We actually did an investigation of 19 states across the country. And through that, worked with those states to update those policies, to update their training for their staff, and to stop using these discriminatory policies. We've seen things where we've seen algorithms used for benefits. So algorithms have long been used in healthcare to do social services, to do benefits at a state or county government level. We've seen algorithms be used where it treats parents with disabilities as less than parents without disabilities in the child welfare system. So all of these things formulated this rulemaking, in addition to public comments, right? We got thousands and thousands of comments as well as stakeholder engagement. So ensuring medical decisions aren't based on stereotypes, ensuring medical accessible equipment. Has everyone in this room ever been weighed? Like literally everyone's been weighed, right? Many people who are in wheelchairs cannot get weighed because most hospitals and clinics do not have accessible scales for people with wheelchairs. They can't get mammograms. I've talked to women who have never had a mammogram in the course of their life. And these women don't live in small communities, they live in major metropolitan areas. So this rule would require medically accessible equipment, including starting within 2 years, accessible scales, accessible tables, and accessible mammography equipment. Following up then for more specialized equipment like MRIs and other things, which when those will have a different timeline, given that they're less frequently used in the healthcare system and more costly. Ensuring web technology accessible. So my mom lives with me. She's 75. She's losing her vision. So she's blind in one eye and her other eye, she has partial vision. So she's a senior citizen, she's Mexican American, and she's also mobilely impaired. So she has multiple disabilities. When we go to the doctor, she cannot use a kiosk. So if you've been to like a LabCorp, if you've been to an urgent care clinic, an emergency department, sometimes just a regular clinic, oftentimes the olden days of like checking in with an actual human are gone. There's still a human there, they're just ignoring you. And you're checking in with a kiosk. I mean, we laugh because it's true, right? And they're checking in with the kiosk. And I'm sure some of you have been in a waiting room where someone's not been able to use the kiosk and they have to go to the front desk or they ask you or someone is kind in the lobby and helps. Oftentimes kiosks are not accessible for people who are visually impaired or deaf or hard of hearing, right? They don't have zoom in features. They don't have auxiliary aids. They don't have things that allow for reading the instructions to you. They're not accessible for people with disabilities. So up until this rule, there was no legal enforceable standard for the government to use. Now we will be able to enforce this, which is really, really important. Things like apps, right? I use apps all the time. I have fine vision and I'm in my 40s. My mom cannot use, like she cannot see a normal app-sized Apple iPhone. So when things like CVS, I don't mean to call them out, but this is true. If you want to have your prescription delivered by CVS, you have to do it on the app. You can't call a pharmacist and ask them for help, and it's not available on their just website. Something my mom spent hours figuring out, which can be very discouraging for someone who's trying to maintain their independence and maintain their life, and not have something that's accessible for people who need these services. Child welfare system, we talked about that. Again, oftentimes in the child welfare system, disability is treated in a discriminatory fashion, whether it's the child themselves or the parent. And this is inclusive. Disability can be inclusive of people with substance use disorders. So we know we just faced an opioid epidemic across the country. There are lots of people who are recovering in active treatment and recovery. If they are in active treatment and recovery, it can be a disability. And that means they're protected under federal civil rights law. So things like skilled nursing facilities saying they're not going to allow a person who's in active recovery and treatment from opioids to live there. We've had cases where skilled nursing facilities have told us people with HIV can't live here. Those are illegal. The fact that those are still happening in 2024, I think, is emblematic of the fact that this rule waited too long to be updated. And then Olmstead, ACA, and Americans with Disability Act. Do folks know what the Olmstead Supreme Court decision is? So there was a Supreme Court decision that went all the way to the Supreme Court where there was litigation over how a person with a disability is able to make choices about their health and human services and care needs, that they be a part of that, so it'd be patient directed, and that they be able to be in the most integrated setting possible. What does that mean? That means that in certain instances, it's in someone's best interest to stay at home with home care workers or home aid as opposed to being institutionalized. And it was a movement away from what at the time was happening, where there was an over-institutionalization of people with disabilities. So again, that's something that happened a long time ago. It wasn't in the regs, we added it into the regs. We are being sued by 17 states over that. States don't like Olmstead because it costs them money. Not all states, just some states. I think the Attorney General here has joined in the lawsuit against us on that, or the former AG. The Affordable Care Act, which has access to home and community services, which is really important. That wasn't inclusive in these regs. And then the ADA, which passed after the 504 law in the first instance, that also wasn't reflective. And most of the ADA is implemented and enforced by the Department of Justice. We enforce Title II, which is against cities, counties, and local governments. So again, oftentimes when we enforce 504, we'll also enforce ADA if it's to a government entity. And then last, prohibits the discriminatory use of value assessments. This gets a little bit to artificial intelligence, again, how we use algorithms or other analytical tools for things like who gets what benefit, kinds of decisions with insurance that insurance companies might use for prior authorization or other medical management techniques. I think everyone knows what prior authorization is now because most insurance companies use it. Sometimes when they use those types of tools, again, they're weighing people with disabilities as different than people without disabilities in a way that's discriminatory, and now that is illegal. And then the last reg we'll just quickly talk about, and I think we can open up for questions, is our HIPAA privacy rule. So when the Supreme Court overturned Roe v. Wade in 2022, we put out a guidance that just reminded people of what everyday HIPAA law required. That you didn't have to hand over records, they were permissible, meaning you had permission under certain laws, but it was not required, and reminding folks to make sure that they were following HIPAA. At the time, what we were seeing a lot of, because when the fall of Roe v. Wade happened, I think a lot of abortion providers are very sophisticated when it comes to HIPAA and following HIPAA, but HIPAA applies to basically every provider, most health plans, applies to your dentists, clearinghouses. And as the fall of Roe v. Wade happened, and that nexus of who had your medical records became wider and not just limited to, say, your abortion provider or your reproductive health care provider, we saw that people were just sort of handing over full force records without doing a lot of oh my gosh, what am I trying to say? Redaction, like de-identifying the data, thank you. De-identifying the data for purposes of protected health information. So we put out this guidance, President Obama, or excuse me, sorry, can you tell us the end of the day? You can laugh, it's okay. President Biden signed 4 executive orders post Dobbs, which is the Supreme Court decision. One of those directed HHS to do conversations all around the country about federal compliance with federal civil rights and privacy laws. So I have been to every single state that has an abortion ban. I have visited and or done a Zoom call with doctors, lawyers, advocates, and others in the community to talk about current laws. And in a lot of those conversations, we were still getting a lot of anxiety about how patient medical records were being sought. So one example is Senator Wyden, Ron Wyden is the current chair of the Senate Finance Committee. He's from Oregon. He did an investigation simultaneous with these conversations, and he basically audited every single pharmacy across the country. And what he found was that when law enforcement came in, regardless of what their request said, whether it was, I would like Melanie Fontes' records, or I want any woman that had mifepristone, which is medication abortion, or misoprostol, which is used for miscarriage management, any of those records, they were really, really broad. Pharmacies were just handing over records, period. And so we then took that information from these conversations we were having, plus this investigation Senator Wyden did, and put together and went a step further and prohibited the use and disclosure of your protected health information. So like your dates of care, the kind of care you received, things that are in your medical file, to preclude that in certain situations. Because what was happening at the time, so I would say one, after Dobbs happened, across the country, there was a lot of chaos. People didn't know what the heck they were supposed to be doing. It varied by where they were. And I don't impute bad faith. I think a lot of times in instances, especially with pharmacies, they were getting some sort of directive from the top, but those can vary wildly by the region you're in and where you are. And the lack of training that was happening wasn't necessarily happening in a way that allowed for patient privacy. So we actually, based on that, put this new rule forward. What this new rule would do was it would preclude or prohibit the use and disclosure of your protected health information when it is sought to go after someone for seeking legal reproductive health care. So seeking, facilitating, providing, obtaining legal reproductive health care, meaning you're going to get legal reproductive health care. Someone's just trying to target you for the type of care you're getting, even if it's legal. Now, I can't undo Dobbs, right? That's not my job. And the Supreme Court didn't give me that power, nor did Congress. So this won't undo Dobbs, which is a question I get a lot. What it will do is protect that privacy and that medical privacy. Because again, what was happening was women would travel from a place like Missouri to California and then come home. and they were be so scared when they came home if they needed follow-up care, they wouldn't get follow-up care, or B, their records were being sought when they were in California, including the provider in California, and when they came home, their home providers were also being asked for medical records. Again, just for the act of having legal reproductive health care. So this rule would preclude that when it is authorized under federal law, including the Constitution, and when it's legal in a state. So again, we tried to draft this in a way that allowed for continued legitimate law enforcement activities to occur, but also to protect that privacy. Because Congress didn't establish a privacy measure. When Congress passed HIPAA in 1999, they said if they didn't come to terms on a privacy bill within a 3-year period, that would then be delegated to the US Department of Health and Human Services. Well, they didn't do it in 3 years. It did get delegated to the US Department of Health and Human Services Secretary, which is delegated to us. So it's within our authority. We are being sued on it twice in Texas by the Texas Attorney General, and then I think the American Defense Fund. That's what it's called, ADF. Alliance Defending Freedom, that's what it is, Alliance Defending Freedom, sorry. But so this took effect this summer. We have not enforced it yet. We won't actually technically start enforcing it till December. My guess is there will be some court things happening in the next couple of months on this. And then as I talk about what's going to happen in incoming administration, my guess is that they probably change this rule wildly or just get rid of it. Oh, was I on the wrong slide the whole time? Sorry, this is this slide, sorry. So I'm happy to take questions now. The last slide is just my contact information. Or if folks have specific questions about anything I went over, or you want to just talk more generally, I'm happy to take questions.
Before we take a question.
Oh, sorry.
We're just going to make a quick technological shift, and I just want to thank you for these fantastic remarks.